I'm Dr. Aravindan R, Vattikuti Robotic Fellow from Manipal Hospital under mentorship of Dr. Somashekhar. Yeah, moving on from the perspective talks, my talk is, for the next few minutes I'll be talking about our study or our work in colorectal surgeries. So as we know, robotic surgery has a main application in the colorectal procedures. So similar to that what urologists has told, so because of the pelvic anatomy, so open surgery or laparoscopic surgery has its own own restrictions. So robotic surgery is a main boon in that restricted pelvic anatomy. So the major advantage comes with the preservation of the fine nerve plexus, which are important for the bowel and bladder functions. So like any other new techniques, this also has a considerable learning curve, and surgeon has to do considerable number of cases to be confident in doing the difficult steps. So coming to the definition of the learning curve, it's usually defined as a number of cases a surgeon has to do in order to reach the level of competency compared to that of the standard standard procedures. So typically the learning curve is as a sigmoid shape with slow beginning and steep acceleration and ultimately the plateau. So as the proverb goes, like all the procedures will not have the same learning curve, or all the surgeons will not have the same learning curve for the same procedure. So some procedures like probably like a hysterectomy might have a faster curve, and something like esophageal surgeries or colorectal surgeries might have longer curve. So most of the studies have assessed the learning curve in the following measurements, endpoints, like docking time, console time, overall operative time, and number of lymph nodes harvested, and the margins. So coming to our study, the study was started from 2011 once we had a robot, and around 221 cases have been studied, and 3 of our leading consultants who are well trained in the open surgeries were considered for the studies. It is a prospective analysis done of docking time and then console, and comparing the male surgeries versus female patients, or the type of surgery, that is LAR or APR. So our port position or the docking was a little bit different from that of the intuitive procedures, and the robot docking comes from the left side of the patient along the axis of the sigmoid colon. Modified centro side docking was done, and single docking and hopping technique was used. We usually always follow the steps, every step in the same step in the every surgeries, every time. So initial metastatic survey of the abdomen was done, followed by identification and isolation of the IMA and IMV, and separation of the pelvic parietal peritoneum from the visceral peritoneum, and the visualization of the nerves and separating them. Then the dissection continued from the medial to lateral, visualization of all the 3 tubular structures, then mobilization of the splenic flexure, followed by pelvic dissection and mesorectal excision, and finally assessing the probable line of transection. We usually use ICG and decide the line of transection, and followed by line of transection we make a small incision, open, and extrusion of the specimen was done, and anastomosis was done. So this was the first step where we identify the IMA and separate it from the nerves posteriorly. So this is a small video. This is a small video of pelvic dissection, where initially after a few minutes of pelvic dissection, umbilical tape is passed, and it is used to pull the sigmoid colon and give the traction. Then the posterior dissection was done and nerves were separated. Once after that, the lateral dissection, finally the anterior dissection and separating from the seminal vesicles and prostate was done. Ultimately, once the pelvic floor is reached, the specimens looks like, the space looks like posteriorly the inferior hypoglossal plexus and right and left nerve plexus are seen properly and protected. Then bilateral ureters were seen, and the pelvic floor muscles, levator muscles, and the rectus stump is seen like this. So we have published this article. We have published this article of our port position and docking in the Journal of Minimal Access Surgery. So coming to this is the first step what I was given, or I had done in the during our training, like hitching the bladder to the anterior abdominal wall. So then coming to our results, the first is the docking time. An average docking time of about 15 minutes is taken. So, but now after so many these things, we usually dock with 8 to 10 minutes, and the docking time decreased reached the plateau level at around 20 cases. Once the OT staff, assistants, everyone were quite accustomed with the surgeries. This is the plot showing the docking time. Then coming to the control time and overall operative time, our proficiency reached at around 12 cases of about 2.5 to 3 hours, and total operative time at around 3 hours. And target number of lymph nodes of 15 were reached at around 9th case. Comparing the male pelvis versus the female thing, as expected, in the females it was quite easy, and the learning curve dropped more for the female patients. And comparing LAR versus APR, since extensive splenic flexure mobilization was not needed, the console time was comparatively less for the APR. But when we take for the overall procedure, overall surgical time as such, perineal dissection required some time, and APR was quite, APR took more time. So the surgeon console learning time, the Kusum curve show the change in the direction at around 12th case. Coming to observations, the overall console time of about 2.5 minutes was reached in our study at around 12th case. Coming to functional assessment, all the patients underwent the removal of the catheter on the post-op day 2. Few patients, especially elderly patients with prior some bladder outlet obstruction, went for retention, around 7 patients. They required recatheterization and removal of the catheter later. And the post-vagal residual volume was checked at, by ultrasound at 1 month, and the erectile dysfunction and retrograde ejaculation were evaluated with the help of QOL questionnaire. This was our study, like significant post-vagal residual volume was at 1 month was seen in 4% of the patients, and erectile dysfunction at 18% of the patients. These are some of the studies which shows the reach of the learning curve at around 15 to 20 cases, and our study was almost similar or better than that. That might be because of we follow the same we follow the same port placement position for all the cases, and the fixed protocols and the steps of the surgeries were followed. So coming to how can we shorten the learning curve with the presence of mentor, or the following on optimal angle of docking, optimal port placement and tissue handling, and self-auditing of our videos and going back to our videos and seeing what mistakes we are doing and changing these things in the next time. So with proper mentoring or proctoring, if we can curtail this learning curve, and it can make it more steeper. With dual console is a boon and can steepen the learning curve. Thank you.